Good evening and warm welcome to all the dignitaries present here. I am Shwastika from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by Indian College of Anesthesiologists. So, the focus of today's session is imaging for anesthesiologists. Now, I would like to invite Dr. Vijish Venugopal sir to proceed with the session. Over to you, sir.
Good evening, Sastika and Sanish for airing us. Thank you. And all my colleagues who are present here, and I welcome you all to the college webinar. The college is doing the webinar continuously for the last 40 years, and probably we have reached that height that nobody is going to claim this particular top person in the world to have a continuous webinar on a fixed day or every week. Good. Let us see how far we can carry on with this particular program. We definitely hope that we could continue this as long as the college continues in its activities. Friends, the college is progressing. Well, you know by now from our activities, and you have seen the type of courses which are being run by the college. We are not running any conventional course. We are running some short courses. Certain aspects which is not dealt very well during the postgraduate days is being taken out and being run as a short-term course. Some are online, some are offline courses. And all these particular courses is going to give a definite impression on what you should know. And they're going to give you a skill on how to carry out the work related to that particular area. Where the future of us depends on all these small areas where we have to have extra competence to carry on in our work as well as show and endure others. And we are progressing, as you saw, in our radiology program, oncology program, cardiology program, thoracic, and all these are being done regularly for the last 8 years. And we have something like 7 courses, and occasionally we'll have 8 courses a year. Anyway, that's all going on, and you may be able to get more information either from Dr. Sunny, who is a registrar to all the courses, or say the college, as well as from Dr. Murli Kanji, who is the dean of the college. And if you want to know anything overseas about the courses, or whether any course overseas, well, you can contact directly Dr. Kumar Ulani, who is our international dean. Well, friends, with this, I am opening today's program. Today's program is a well-awaited program. It is mostly a YOC, where it's mostly done to make us prepare, make my students, make my colleagues prepare for examinations and to update their knowledge. It's mostly on the radiological principles and radiology, as well as ultrasound and their course. All these things are combined and will be shown in the next 110 minutes by Dr. Vijish Venugopal and his team. Dr. Vijish Venugopal, an erudite speaker, good academician, and he is a principal at KMCT Medical College, Calicut. Till recently, he was head of the department. Since our last 6 months, he is a principal. And well, he is going to help by his colleagues in the department, Sunny, Shahid, Elizabeth, Jomy, Dhivya. Well, I may not be knowing each one, but I'm sure Vijish will be introducing them to you at every particular point. And all my colleagues will please listen to Vijish and his team and enjoy the webinar. And over to you, Vijish, for you to start.
Thank you very much, sir. Good evening, everyone. At the very outset, I would like to thank the Radhakrishnan sir and Sanish and the officials of Indian College of Anesthesiology for giving KMCT Medical College and my colleagues an opportunity to talk regarding imaging for the anesthesiologist. We are planning to do this in 5 small sessions of 20 minutes each, and with a small introduction by me in the beginning. I hope the slides are visible.
Yes, please.
So it's moving, right, Sanish?
Yes, it's fine.
Yeah, so imaging, anesthesiologists have been using imaging since probably the last 2 decades, and we use various imaging modalities to enhance our patient safety and to improve the efficacy of the procedures that we do. So the integration of imaging techniques into anesthetic practice, it has revolutionized certain areas in anesthesia like the airway management, regional anesthesia, and intraoperative monitoring. So the key imaging modalities that we use in our daily practice are mainly the ultrasonogram, the radiographs. It could be the plain radiographs or the fluoroscope, the CT scans, and the MRI. So each imaging modality has its own advantage and disadvantage. Now, if you look at fluoroscopy, it's readily available in the operating room, and it gives good detail of bony structures, but the disadvantage is the radiation exposure to the patient and to the operator. Now, if you look at the CT scan, it definitely provides high resolution images. And also nowadays you have the advantage of 3D reconstruction, but the disadvantages are again high radiation exposure. If you look at the modality of MRI, there is no radiation exposure, there is high resolution image, and there is very good soft tissue images with good 3D reconstruction available. But the disadvantage is that there is a magnetic field hazard, and it is not portable, it is not real time, and it's quite expensive. So we come to ultrasound. Ultrasound, there is no radiation exposure, the real-time imaging is there, portability is there, relatively low cost. The disadvantage is limited penetration. And so these are the different types of imaging available, and in applications of these things in anesthesia, you have during your preoperative assessment, imaging is vital in evaluating patients with complex medical history. It helps in identifying anatomical variations. You can assess the severity of vascular and cardiac diseases. You can plan and guide the surgical approach also based on detailed anatomical information which can be derived from your imaging studies. Now, if you look at ultrasonogram, it's used for regional anesthesia and interventional pain management, where the anesthesiologists use ultrasound to guide needle placement and monitor the spread of local anesthetics near the nerves. And it's also used for venous access, where in case of difficult venous access, ultrasound plays a very important role. Nowadays, you can use the ultrasound for epidural space identification, as well as the transthoracic, as well as the transesophageal echocardiogram can be used for cardiac imaging. And ultrasound also plays a very important role in evaluation of the airway and for your lung examination. So much so that nowadays you find that the ultrasound is a very integral part of your anesthesia machine. Some of these machines even have an ultrasound probe as well as the monitor attached to it. The important one is the point of care ultrasound, where you can nowadays use the ultrasound probe to look at the optic nerve sheath and look at the ICP measurement for the airway, whether the ETT, the endotracheal tube localization, looking at the anatomy of the airway, looking at the pulmonary system, you can diagnose pneumothorax, pleural effusion, airway space disease. Coming to the cardiac side, you can look at the ventricular function, the valvular function, and the volume status. You can use ultrasound for vascular access, and coming to the abdominal area, you can look whether the patient is adequately fasted by looking at the gastric volume. So the point of care of ultrasound definitely plays a very important role. So much so that we now can decide whether the patient has a difficult airway, looking at the airway examination, which we have a topic which will be dealt with by Dr. Sunny later. And even during your cardiac compressions, the point of care ultrasound can be used. During the periods of interruption, you can look at the various views, as well as you can, while the CPR is being continued, you can look at the IVC and the other areas. Now, whether this point of care ultrasound is beneficial to the patient, definitely the meta-analysis for a patient POCUS outcomes in patients with acute onset dyspnea has shown that it reduces time to diagnosis, reduces time to treatment, decreases length of stay, as well as it improves the rate of appropriate treatment. So POCUS, definitely the point of care ultrasound is going to stay and it's going to be beneficial to your patients. And presently you have a variety of probes, so much so that it can be carried in your pocket, and it's probably going to replace the stethoscope. And it's available, the GE, the Philips, the Sonosite all have wireless probes which can be paired via the Bluetooth to your mobile, and you can scan the various parts of your patient's body. And now we have the augmented reality in ultrasound guided regional anesthesia. And this is a needle trainer which uses a retractable needle and a virtual image overlay to simulate needling non-invasively on live participant using an authentic live ultrasound scan. So this enables trainees to develop hand-eye coordination, optimum positioning and accuracy in ultrasound guided interventional procedures in realistic clinical environment with minimal risk. This is another one where, and this is an anatomy guide. There is an intelligent ultrasound system, which is a system where the artificial intelligence plays a role. It has been developed the use of B-mode ultrasound video for specific regional nerve block regions. Each video is broken into multiple frames, with each frame receiving a colored overlay of specific structures identified as other landmarks, safety structures, or targets. Now, this is an example that I have shown here of a peripheral nerve block, the adductor canal nerve block. So information used to train the algorithm is similar to that used by an inexperienced operator in the clinical practice by identifying relevant anatomy. So in this model, you can see that there is the sartorius muscle and the adductor longus muscle, as well as the femur. And these were identified as landmarks, and the optimal site for blocking is the region where between the two medial borders of these two muscles. So the optimal block site is the region which is shown here, and the femoral artery is labeled as a landmark and the safety structure. And the saphenous nerve that is there in the adductor canal is labeled as the target. So the intent is to assist the operator in identifying the nerve and the correct site to target for the block. So this definitely can also be used when you use for the artificial intelligence can also be used when you use ultrasound for cannulating your central veins also, where again the anatomy guide can help you. Now, coming to the computed tomography imaging, it offers the ability to generate high quality images that define the anatomy of deep structures. For preoperatively, we look at CT scans, especially in thoracic surgery. When you suppose you have a retrosternal goiter, you look at whether there is compression of the airways. Similarly, you can measure the left bronchial width for deciding on what size of the DLT that you're going to use. It has been also used to guide needle placement, to suggest modification of existing techniques, and to evaluate local anesthesia spread. Newer machines, they offer the potential for CT fluoroscopy with real-time needle guidance, but the disadvantage is exposing the patient to radiation. Coming to magnetic resonance imaging, it's free from radiation, but its location inside the radiology department, together with constraints of magnetic field safety, its clinical application. So staff and patients with implanted ferrous magnetic materials should not enter the magnetic field. And needles may not be used near the magnetic field, so real-time guidance is not possible in the MR suite. So while MRI is better than CT at demonstrating neural tissue, it currently remains as a research tool. So I would like to conclude this introduction by saying that the integration of imaging technologies into anesthetic practice has significantly improved patient outcomes. Anesthesiologists are now better equipped to manage difficult airway, perform regional anesthesia with precision, and to monitor patients during complex procedures. As technology advances, ongoing education and training in these new modalities will be essential for the anesthesiologist to maximize their benefits in clinical practice. So this is just a brief introduction that I wanted to give, and we move on to the first topic of the day that will be delivered by our professor and head of the department of KMCT Medical College, Dr. Sunny Alex. So Dr. Sunny Alex, he is presently the professor and HOD at KMCT Medical College. He's done his MBBS from Calicut Medical College, MD from Mangalore, and he also has a postgraduate diploma in medical law and ethics from the National Law School of India University, Bangalore. Over to Dr. Sunny for his talk on ultrasonogram of the airway.
Audible?
Yeah, audible.
Thank you, Vijish sir, and thank you ICA for this opportunity. Without wasting any more time, I'll just.
Can you just increase the volume? It's not.
Okay. Now?
Yeah, better.
Okay. So without wasting any more time, I'll just start off with my topic. I have chosen the probably the safest of the imaging modality of all. That is ultrasonography. And that is ultrasonography of the airway. So what is so special about the ultrasonography of the airway, or what is different from other areas? The answer is simple. Ultrasound doesn't like air, and your airway is full of air. So ultrasound waves are reflected by air. So the structure surrounded by the air is difficult to visualize. And anesthetists can use the ultrasound to identify difficult or abnormal airway, to perform percutaneous cricothyroidotomy or tracheostomy, for confirmation of an endotracheal tube placement, and to rule out an esophageal intubation, for regional blocks for airway management, for screening obstructive sleep apnea, and also for evaluating vocal cords and epiglottis. So for doing the sonoanatomy of the airway, the position of the patient has to be supine with head and neck extended, just like our sniffing position. And the probes used are for the infrahyoid superficial structures, we go for the high frequency linear probe. And for the suprahyoid deep structures, we choose the low frequency curvilinear probe. And the views are usually preferred are the sagittal, parasagittal, and the transverse view. And always remember, hypoechoic means black and hyperechoic means bright. So we'll start off with the first one. This is the sagittal view when we keep the high frequency linear probe over the suprasternal notch. And this is the view obtained. You can see I have marked A, that is inverted U-shaped hypoechoic. Hypoechoic means black. So you can see the inverted U-shaped structure. Below that, an hyperechoic bright line. And below that hyperechoic bright line, you can see so many lines and a black view. And surrounding the A, you can see B, which is almost a homogeneous structure on the anterior aspect of this structure. And on the left side, you can see a collapsed structure. So can you identify A, B, and C? You can put it down, put the answers in the chat box. Vijish sir, can we see the chat box?
No, the chat box is separate for them.
Okay.
And it's okay, we can continue.
Okay, so you can check your answers. I'll move on with the answers. So this is your trachea. I'll show the scanning also. So this is the high frequency linear probe just above the suprasternal notch. And see, you can see the inverted U-shaped ring. That is your tracheal cartilage. So this is your tracheal cartilage, the black one. Below that, what you are seeing is a hyperechoic bright line, which is nothing but the air mucosal interface. So below the air mucosal interface, the ultrasound waves cannot be transmitted. So Whatever you are seeing below this hyperechoic line is just reverberation artifacts. And the violet structure surrounding the homogeneous structure surrounding the trachea is obviously your thyroid gland with the left and right lobe and the isthmus. And the collapse structure seen on the left side, that is your esophagus. Esophagus will be obvious only when the patient swallows. Then you can see the peristaltic movements. So again, the same thing. You can see the high frequency linear probe over the suprasternal notch, just above the suprasternal notch, the tracheal cartilage, air mucosal interface, reverberation artifacts. In between, you can see hyperechoic shadows that is called as the comet tail artifacts. And anterior to the trachea, you can see on either side hypoechoic structures. Those are the strap muscles. So at the same level, you can take the probe slightly parasagittal. Once you take the probe parasagittal, again, this is your trachea. You can see that homogeneous structure on the side, that is your left lobe of the thyroid gland. This is your esophagus, and that is the carotid artery. So now this is, as I have already told you, this is the carotid artery. This is the trachea. You can concentrate here, that is the esophagus. When the patient swallows, you can see the peristaltic movements. That's the carotid artery. This is the esophagus. When the patient swallows, you can see the peristaltic movements. See, that is the peristaltic movements in the esophagus. That is the way you identify the esophagus. That is your trachea. So this is how a normal thyroid gland looks. See, that is the homogeneous nature of the lobes and the isthmus. But at times, you will get a picture like this. On the left side, it is almost homogeneous. But if you see the right side, you can see some hypoechoic black structures which are cystic and some hyperechoic areas which are solid. So this is a complex thyroid nodule. So now you can move the probe slightly more cephalate. Then you can see another structure appearing, which is a horseshoe shaped structure, which is again slightly hypoechoic but bigger than the tracheal cartilage. So, and you can see the air mucosal interface there also with reverberation artifacts. So what is this horseshoe shaped structure? You can keep guessing. I'll show the scanning video of that structure. See, is taken it a little more carefully, and you can see the horseshoe shaped structure, which is the nothing but the cricoid cartilage. That is your cricoid cartilage. So after that, you can just turn the probe longitudinal. At the same level, you can turn the probe longitudinal. Then this is the view you will get. So you can see a string of beads or the string of pearls appearance of the tracheal cartilage. So if you trace the tracheal cartilage from below upwards, at one point there you can see a hump and a bigger cartilage. That is your cricoid cartilage. You can compare the size difference from the tracheal cartilage and the cricoid. So this is the scanning view of that. You can see the string of pearls appearance here. See, these are the tracheal cartilage. Here is another tracheal cartilage, and suddenly there is a hump, and there you see a bigger cartilage. That is your cricoid cartilage. And if you trace the cricoid cartilage a little more cephalad, you can see a membrane running from the cricoid cartilage towards another bigger cartilage. That is your thyroid cartilage. So this membrane is the cricothyroid membrane. It is very important to identify and mark the cricothyroid membrane. So that is it, how to identify the cricothyroid membrane, and I'll show you how to identify and mark the cricothyroid membrane. See, this is the cricoid cartilage. This is the area where the cricothyroid membrane will be and this is the thyroid cartilage. So just see the scanning. Once you get this picture, what you can do is take a needle and pass it below the probe, and you can see the needle coming from up down, and when it reaches the level of the cricothyroid membrane, you can remove the probe and mark the cricothyroid membrane there. This you can do for all your anticipated difficult airways and during an emergency fauna. So after that, once you have identified your cricothyroid membrane and cricoid cartilage, you again shift your probe a little more carefully. Then you will get a picture like this. There you can see A. What I have marked A is a inverted V-shaped structure. See, a inverted, slightly hyperechoic V-shaped structure, and below that, two on either side hyperechoic structures, and below again oval-shaped hyperechoic structure. This is the view when this inverted V-shaped structure becomes calcified. So what is A, B, and C? So A is your thyroid cartilage. Thyroid cartilage is identified by this inverted V-shaped appearance. Sorry for that. And these are your false cords. And below that, your arytenoid cartilages. This is how the thyroid cartilage will appear when it is calcified. This is just to show that if you keep a gel pad between the probe and the skin, you will get a clearer picture. Now, you have already identified the inverted V-shaped structure, that is the thyroid cartilage. And anterior to the thyroid cartilage, here you can see some hypoechoic structures on either side. Those are your strap muscles. These are the strap muscles. This is your thyroid cartilage. And medial to that, these two black structures, that is the vocalis muscle. And your vocal cords are delineated medially by the presence of a hyperechoic structure, that is your vocal ligament on either side. So this is when the vocal cords are abducted. You can see the vocal ligaments on either side with the space in between. But when it is adducted, you can see the vocal ligaments on either side coming to the midline, and the arytenoid cartilages are elevated symmetrically. So you can see he has taken the probe slightly more carefully until he sees a inverted V-shaped structure, that is your thyroid cartilage and the vocal cords. The vocal cords you can see better when the patient phonates. Just concentrate on the vocal cords. Now the patient will phonate and it will come to the midline. See, that is the movement of the vocal cords when the patient phonates. This is another method to identify the cricothyroid membrane, that is called as the TACA technique. In the TACA technique, once you have identified the thyroid cartilage, that is your inverted V-shaped structure, you take your probe slightly corded, and then you can identify the air mucosal interface as the bright line, hyperechoic line. That hyperechoic line or the bright line corresponds to your cricothyroid membrane. So once you see that bright line, you can, for confirmation, you can again take it slightly corded. Then you can see your cricoid cartilage. So between your cricoid cartilage and your thyroid cartilage, that hyperechoic line, that is corresponding to the cricothyroid membrane. And to confirm, what you can do is once you see the cricoid cartilage, again take the probe little cephalate, and then again you can identify the same bright line or the hyperechoic line, which is the cricothyroid membrane. This is another way to identify the cricothyroid membrane. Okay, proceeding with the scanning, again cephalate. Once you reach a little submandibular region, suddenly you are seeing the face of a frog. If you can appreciate, this is the eyes of the frog. A, both the A's represent the eyes of the frog. C will be the lip, and the B will be the nose area. So what are those structures? This is at the level of the thyrohyoid membrane. So both the A's will be your strap muscles. Your skin. This is anterior. This is anterior and this is posterior. The skin, subcutaneous tissue, your platysma. Then comes your strap muscles on either side, and this lip-shaped structure, that is your epiglottis. And above the epiglottis, this area is your pre-epiglottic space. So the distance from the skin to the pre-epiglottis space, that is taken, that can predict a difficult laryngoscopy. So below the epiglottis, this hypoechoic structure is the epiglottis. Below that, you can again see a air mucosal interface. Okay, this at the same level, if you take it slightly left parasagittal, again, you can, this is anterior, this is posterior, this is your strap muscle. Here you can see an acoustic shadow, and above that there is a hyperechoic structure, that is your hyoid bone. Just because it is a bone, there is the below that there is the acoustic shadow, and this is your thyroid cartilage. So between the thyroid cartilage and the hyoid bone is your thyrohyoid membrane, and this is your pre-epiglottic space. Again, the epiglottis, the air mucosal interface. So now, if you go to an extended submandibular view, you can, it will be the floor of the mouth. So you can see the mylohyoid muscle, the geniohyoid. Here, that is the hyoid bone with the acoustic shadow. Sorry, that is the acoustic shadow. Here you can see a structure with a striated appearance. This is your tongue. Then these striations are due to the presence of intrinsic muscles of the tongue. This is your sublingual fat. See this, this is the epiglottis. This acoustic shadow found by the hyoid bone and the epiglottis. When the epiglottis becomes edematous, it will resemble the alphabet P. That is called as the P sign in epiglottis. The vertical limb of the P is formed by the hyoid bone's acoustic shadow, and the other part of the P is formed by the edematous epiglottis, which I will be showing in the next slide. See, this is the vertical limb, that is the acoustic shadow of the hyoid bone, and this is the edematous epiglottis. This is called as alphabet P sign found by the acoustic shadow of hyoid bone and swollen epiglottis. Now, very important, how to identify a tracheal intubation to make sure that the tube is in the trachea. You can see there is two bright lines there. So this is called as the double tract or the double lumen sign when the tube is in the trachea. That is the longitudinal view. Again, you can see two bright line. That is the double lumen sign. So now we are seeing two trachea there, a big one and a small one. So what is this A and what is B? So this B is your esophageal intubation. This will be the picture when the tube goes inside the esophagus. When the tube goes inside the esophagus, another trachea appears. So this is called as the double trachea sign of esophageal intubation. So this is the picture I am going to show you, the scanning. This is the trachea, this is the thyroid, this is the esophagus. As soon as the tube goes inside the esophagus, you can see one more trachea appearing here. And when the tube goes inside the trachea, the movement will be only in the tracheal shadow and nothing will be there in the esophageal shadow. Just see the esophagus. See the one, the tube is inside, another trachea is appearing there. So that is called a double trachea. And see, now the tube is in the trachea, the movement is only there in the trachea. You can see once more the video there. That is your double trachea. This is your tracheal intubation when the movement is only in the trachea. Okay. And another indirect method to confirm an esophageal intubation or rule out an esophageal intubation is the bilateral sliding sign that my colleague will be dealing in detail later. So absence of bilateral lung sliding sign indicates esophageal intubation. Then ultrasound can also be used to predict an obstructive sleep apnea by measuring the width of the tongue base and also the lateral parapharyngeal wall thickness. How to measure the lateral parapharyngeal wall thickness? The patient should be in the supine position on a 35-degree soft pad with the inframeatal baseline. This is the inframeatal baseline that should be perpendicular to the scanning table. And your probe should be kept on the lateral side of the neck, just below the occiput. And this is the picture you will see. If you put the Doppler, you can see that this is the internal carotid artery. And here you can see a hyperechoic bright structure, that is your lateral pharyngeal wall. So if you measure this distance, that is your parapharyngeal wall thickness. Then how to use USG to confirm an LMA position? If the LMA is correctly placed, the arytenoids which we have already seen in the previous slide, that will be elevated symmetrically. But if there is a malrotation, the arytenoids will be elevated asymmetrically. And the target study that has shown that an ultrasound guidance improve the success rate of first percutaneous dilational tracheostomy attempt and puncture accuracy better than compared to the traditional landmark technique. And ultrasound can also predict a post-extubation stridor. That is, you have to see the limited air column width difference at the level of the vocal cords. And how to predict the size of a left abdomen tube, bronchial tube? You have to measure the outer tracheal width just above the sternoclavicular junction. That can be used to select the size of a left-sided abdomen tube. Outer tracheal width just above the sternoclavicular junction. And for prediction of the required endotracheal tube size, you have to see the subglottic diameter at the level of the cricoid cartilage. And your outer diameter of your best fit endotracheal tube should be 0.1 to 1.7 millimeter less than this subglottic diameter. And it has been shown that USG is a better predictor than your agent height-based formula. So this is your cricoid cartilage, which we have already seen. And this at the level of the cricoid cartilage, you see the subglottic diameter. And your tube's outer diameter should be 0.1 to 1.7 mm less than this. Then we have the IAM framework for airway ultrasound, which is actually a structural approach to lung POCUS, which has been adapted for airway ultrasound, where I stands for the indication, A for the acquisition of image, and IM for the image interpretation, which we have already gone through for confirmation of the endotracheal tube intubation, rule out esophageal intubation, and to identify the cricothyroid membrane. To predict a difficult laryngoscopy, we have the hyomental distance ratio, which is a very sensitive predictor of difficult laryngoscopy. Shorter the hyomental distance ratio, intubation is going to be difficult. Then you can also measure the pretracheal tissue at the level of vocal cords. If it is 28 mm or more, that also will predict a difficult laryngoscopy. And anterior neck thickness at the level of hyoid bone and thyrohyoid membrane. That is also, if it is more than 28 mm, is a better predictor for difficult laryngoscopy. So to summarize, a sound knowledge of the sona anatomy of the upper airway empowers anesthetists to leverage ultrasound in many airway-related conditions. Transverse and parasagittal views aid in diagnosing supraglottic, glottic, and infraglottic airway conditions, thereby improving airway evaluation and management strategies. Thank you.
Thank you, Dr. Sunny, for that elaborate talk on ultrasound of the airway. We'll take questions at the end. So we move on to the next session. Kindly share the screen, please. Dr. Jomy. So the next session is on CT as an imaging modality for the anesthesiologist. And to deliver this talk, we have with us Dr. Jomy P. Thomas, who is the Associate Professor of Anesthesiology at KMCT Medical College, and he's also a member of the NAC task force at our institution. Over to Dr. Jomy for his talk.
Good evening. Today we are discussing about CT as an imaging modality for anesthesiologist. So actually this is not a direct specialty with us because most of the facts are primarily dealt with the radiologist, and we have more of the slides that we have taken or incident findings that we have from the radiology department, so that we discuss about the CT, and maybe we'll have a small discussion about what is happening in the CTs. So CT or computer tomography. So actually the findings that we find is like a child viewing from through an aeroplane window. So he's quite curious to find something outside. Few facts are known, few facts are known or not known, but he's just visualizing and trying to learn from it. So we are going into it. So a CT, the word comes, tomography comes from a word called tomo, which means cut. So here we are having cut sections in multiple ways, in axial way, helical way. It's a word derived from a Greek word, and Sir Godfrey Hounsfield invented CT. So it was a great invention that time, and in 1972 he got our Nobel Prize for this invention. Now we'll move for the parts of CT. As we know, we have a round structure which is called a gantry, and then inside that we have a revolving X-ray tube. And on one side and opposite sides, we have multiple regulators. There's a patient couch, and then there's a patient console, which is outside for where the radiologist can watch. So as we can see in this image, we can see that X-ray beams are sent from multiple directions. So we are getting multiple slides, and each of these slides, the X-ray has been stored, and it takes a 3D it takes a 3D formation, and finally the results all are assimilated in a computer. So how which is the section that we want? That it's depending on how the radiologist thinks. So actually, the eye sees what the mind knows. So if a properly educated radiologist, a person has an idea that what has to be found out. So that also comes from the clinical correlation of how a request goes for a CT. Imagine a CT for a head goes, the proper history should be mentioned. So the radiologist also will have an idea that, yeah, this should be my point of focus. So he will he will put the scanning machine in that way that he gets the slides in the way that he expects these three are my diagnosis, and this could be it. That is the way that they set the settings. So it's all about the knowledge and thinking of the anatomy and the common probabilities of a clinical scenario. So now the more important thing that what we see here is the densities on a CT scan. So CT, as we know, CT, there's a CT number. So from here you can see that air, CSF, and bone. So the number is it is approximate. There's a 2,000 units that we can differentiate about these colors in CTs. And we start from the basic. We keep the baseline as water, and the plus goes for plus 1,000. We go up to the bone, which is the hardest one, and air, which is the least densest one. So according to there are 2,000 colors, and though it's not visualized, the more the changes are not so visualized by our human eyes, but the numbers are 2,000, and uh, because there is number 2,000 is there, now we have to adjust according to what our need is. So that comes called windowing. It means that if you want, we will go into a small section out of it with a small plus or minus range, so that we will get the structures only that what we are intending to look out of it. So here comes windowing, and there is a two terms called the window level and the window width. So the brightness is adjusted like the window level, and the contrast is adjusted by the window width. To be more specific, I'll show three pictures here. Like the first one, as you can see, is the brain window. So it is subjective of more of the changes that what you focus on the brain. The second one, you're only looking for the soft tissue changes. And the third one is showing that what has happened in the bony windows. So actually, this is of the same one. You are taken of the different window levels, to be frank. Now, applications, as Dr. Vijish sir has given a brief introduction prior. One advantage of CT when we consider with other modalities are it is painless and it is fast and it is non-invasive, and it also helps to give a definite diagnosis of tumors. Then we know that it helps us in fluoroscopic blocks, biopsies, and CT helps to delineate more of the bony structures. While soft tissues, we know MRI is good for. And when you get a CT report, the reports are mostly accurate, so that you can, if you're planning for any emergency situations, you can take the patient suddenly to the theater. Then, if you plan earlier, then we can see the abnormalities of the airway and the nasal passage, any other spine, abdomen, and lungs. That is planned ones. We can't get emergencies like that, but planning. If you imagine that we plan for an airway difficulty, we can get an CT prior. And the thing is, I'm comparing to other few modalities, it is cost effective, simple, and widely available. Almost all places CTs are available than MRIs. And one more advantage is there in pediatrics, because firstly, the CT, the taking procedure is very fast, so it is easy. And definitely, as we know that MRI, we have difficulties in keeping patients with clips, prostheses, implants, etc. And coming to the fact about the radiations, now low dose CTs, I mean radiation CTs scans are available, especially when you are looking for few regions, not all regions. And one more thing is that it is less sensitive to movements, but MRI is more sensitive to movements. So you can keep a patient in which is in ventilator too. You can keep which with more accuracy. And because of the radiation, definitely, as I sir discussed prior, radiation is a major fact for CT scans, because you're putting hundreds of X-rays together. It should be avoided during the first trimester of pregnancy. Now, because it's a new topic and we are all novel to it, we'll just put few scenarios to discuss so that we will learn something out of this. So I hope that something will be there to enlighten our gray matter. Yeah. And in chest, we sometimes take HRCT. So here, what we want is we want to compare the size of the airway with the accompanying artery, which should be more or near to equal size. And the HRCT gives better resolution. So with this, I am moving to few clinical scenarios. An 80-year-old patient admitted for TORP, history of having a procedure 1 hour. This patient developed difficulty in respiration after the procedure and was treated. So the X-ray and the CT findings are added here. So you can see this is the X-ray finding and then CT, and patient was treated. And so what is the answer? Like you can comment in the comment box. So we'll see towards the end of it. You can comment the answer in your comment box. I hope you have commented. I'll go to the next slide. So this is a picture of pulmonary edema where you find curly B lines and curly A lines. So now we'll go to a scenario 2. A 54-year-old woman with a past history of hypertension is presented to her hospital with chief complaints of dyspnea and facial swelling and redness when standing up. The patient's symptoms had started gradually 10 months before she went to our hospital and had become more severe over time. She has been posted for thyroidectomy surgery. As an anesthesiologist, you are called to review PAC and a CT attached is given. So, as an anesthesiologist, what are your concerns, plans, preparations, and suspects? So, I'm just adding the picture here. So, you can get through to the CT findings and X-rays also there. Requesting to focus more on the airways, how the size of the airway is. You can just see the trachea, the size, the pictures in multiple levels. I hope you can comment. We'll see the answers towards the last. Up to the next slide. So this is a retrosternal goiter with some compression features. Compression of SVC syndrome is there, and dyspnea is the most common. Like as you know, orthopnea, dysphagia, dysphonia are all other complaints. So what should be, as an anesthesiologist, what should be your main focus? You're going to have a difficult airway. So you have these findings in front of you. So you can't take it as just an emergency. It is a planned surgery. You'll have to plan for an awake fiber optic intubation. You will have to see the difficulties, post-op ventilation if required, brachymalacia, other issues, bleeding, all those things are your major concerns. So this is concerning this. So you get a CT, so it's much conclusive of what you're going to the next day. Rather for the surgeon also, it's also helpful for the anesthesiologist. To the next one. So we'll just have a look into what is compression ratio. So you're just seeing something here. Something is compressing on the trachea. So now the next picture you see. So the index on the severity of compression is measured as something called tracheal compression ratio or TCR. TCR means it's the ratio between the narrowest cross section divided by largest cross section. Sorry, the division is missing in the slide. So you should understand the narrowest part divided by the largest part. So if the narrowest and the largest are same, then it becomes 1. So tracheal narrow percentage is equal to 1 minus TCR. So when there's no compression on the trachea, TCR is equal to 1 and the tracheal narrowing is 0. So according to this, we differentiate how much tracheal compression is there. But only one feature is the one issue is like if the all parts are equally compressed, then the answer is also there won't be any compression ratio. So ideally, the internal diameter of the trachea is 15 to 25 mm in males and 10 to 21 in female. In the cross-sectional area of 250 to 350 mm square, in a volume of 30 to 40 at a total lung capacity. And another factor we should notice is that the transverse diameter of the trachea increases by 10% with inspiration and decreases by 30% when puffing. And during expiration, see this I'll coming later, CT images display a physiological bowing of the posterior non-cartilaginous membranous wall of the intrathoracic trachea, and while the anterolateral part remains unchanged. So we'll just see. So this is an expiratory CT scan. So you can find the inspiratory and expiratory parts size A, B, C, and D. So when the volume gets reduced, you can see that the attenuation also, how this change is happening. It's getting more whiter. And when the volume is increasing, it is more darker. And you can also see the changes of the trachea, how it is moving. Now, another aspect we have to know is the positioning of the endotracheal tube in CT. So this is a coronal CT section. Approximately a CT, the end of the endotracheal tube will be nearly 5 centimeter above the carina. So our measurement should be according to that. If you have how much an endotracheal tube can go up through. Now, as Dr. Sunny sir has discussed prior, here also any incidental finding when we are taking, trichord ring is the narrowest part of the trachea and its diameter determines whether the endotracheal tube can successfully pass through the subglottic region. And transverse diameter and the anteroposterior diameter of the cricoid ring are measured using its lower border. And also CT studies have concluded that an anteroposterior diameter in 2/3 of the population and glottis was the smallest and 1/3 population subglottis was the narrowest part, which helps in predicting the ET tube size. Now we are moving to the next scenario. So measurement of the endotracheal tube is over. Now we'll go to some other parameters. A dotted line is put here. You can see, hope it can be visualized. The measurement refers to the measurement of which. So this is what we have discussed prior, the double luval tube measurement by CT. So you can see it's a left-sided You can just go through the anatomic picture here and just focus on the left main bronchus. So it is more precise than X-ray for measuring the size of the endotracheal DLT tube. It is measured by measuring the tracheal and the bronchial diameter, as well as the cricoid ring. And tracheal width is measured at the level of the 7th cervical vertebra. Because all the features and the bony structures are present, we can measure this easily. And the left main bronchial diameter is measured from around 1 centimeter from the carina. And depending on the tracheal diameter, we go in the following way. So it is also conclusive and helpful for measuring the DLT size. To the next question. A 43-year-old male was admitted to our hospital for SARS-CoV-2 infection. The patient underwent endotracheal intubation and he progressively improved and was discharged. Few days later, patient came with severe respiratory distress. A CT scan and a bronchoscopy shows signs of. So you can see something here. I hope you can focus on more this part and this part. And suggest you on the history also. A patient had been intubated for more than a 10 days period. So definitely this could be, I hope you are commenting on the sections. This is a diagnosis of a tracheal stenosis. Post intubation, a patient comes with complaint of respiratory distress, could be highly suggestive of a tracheal stenosis post extubation. So you can see that mostly this patient has a 71% obstruction. Usually patients come with respiratory distress when they are usually in grade 3. Now we'll move to the next scenario. An 86-year-old man was evaluated for chronic cough. His medical history was significant for a COPD, and he had smoked 1 packet of cigarette daily for 55 years. And he has a barrel-shaped chest with a diminished breath sounds in bilateral lungs. And a CT chest noted an abnormal configuration of the trachea. So I hope you noticed that what was the normal structure prior. Normal structure was how much was the anteroposterior and the transverse diameter. And this figure suggests something much different out of it. And also one instrument is also kept to give a clue. So I hope that I get some comments correcting this for this question. Some more pictures are given. The X-ray is also given. I hope that you can see look into the shape of the X-ray, how it has happened. Okay, so this is our diagnosis Saber trachea or scabbard trachea. So concern with, I hope you have noticed the normal anteroposterior prior. Here the narrow transverse diameter while increasing anteroposterior diameter is happening in the trachea. So you can just see it. The shape has been reversed. So we'll go a new terminology with it. It's called tracheal index. So I hope you can notice this picture, this transverse diameter, which is B, and anteroposterior diameter, which is A. And tracheal index is the transverse divided by the anteroposterior diameter here. This is one parameter that helps to assess the large airway changes in COPD. And it is calculated by dividing the maximum coronal by the maximum sagittal diameter. So definitely you can understand that Saber trachea has a tracheal index less than 2/3. And because of this, air is more trapped in the alveoli. Then definitely you can see that the lung structure is also getting more and more darker. And the normal tracheal index will be definitely, then you should expect it should be 1.4 to 2 because the ratio is reversed. So a few more pictures on the Saber trachea, you can see how the shape of it is and the pictures of it. Now to the next scenario. A 2-year-old boy presents with a history of recurrent cough. Chest X-ray and chest fluoroscopy done show no abnormality. So you can see the chest X-ray. And after 26 days of asymptomatic treatment, a recurrent cough did not improve, and a chest CT scan was performed, and treatment was done. So CT finding is added, a comment. So you can see that chest X-ray is not showing much conclusive anything, but when you do a CT scan, something is there. So we'll go. I hope you have a comment on the answer. Okay. So this is a foreign body in the left main bronchus. Once more, I'll go to the picture. I hope you can note. Visualizing CT is same as as X-ray. We have the sides also on the right and left on the right sides, left and right sides accordingly. So the most important factor we have to notice here that CT becomes helpful is that 90% of the foreign bodies are radiolucent. But the CT detects both radiopaque and radiolucent. So it is more helpful, which is always sometimes missed with the conventional X-rays. So now we are going to the next question. So this is a common scenario that I think we have learned in your UG classes, just adding up a few common lung slides. A chest CT scan is given here. So I have also given some clues for it. What is this pattern? You can see a bee also in this picture. I hope I get some comments. So this is a honeycomb bee. And you can see that. Just observe the CT. It is difficult to teach the CT from the basics because there's a lot of parameters out of it and we don't use it regularly. We can just see and appreciate the slides. So that is why I'm not going for too much explaining for the CT, how to visualize a CT. But common findings we can discuss and we can learn few from it. So we have seen that there is a lot of cystic air spaces. And this is the most common finding in fibrosis and interstitial lung diseases. This is a common scenario that we have been seeing in our ICUs in the COVID times. And we have also been doing many classification according to it. So a CT image of a young male who had fever for 10 days, cough, shortness breath, saturation less, COVID-19. So there's a few slides have been given here. You can just get through the slides. Common terminologies, ground glass appearance. So bilateral ground glass opacities with a posterior predominance, partially filled air spaces. And second one, crazy pavement, more advanced phase. Next. Another airway scenario. A 75-year-old man presents for a hernia repair. History suggests of high-pitched breathing noisy sounds, liquid infections airways, like bronchitis, exercise intolerance, prolonged respiratory infection. CT chest is done, and you can find something here. I hope you can note the chest, the trachea, the size. So history is very important suggestive here. There's some strider is also there. I hope I get some comments. So this is called a tracheobronchiomalacia. Malacia is a word derived from the Greek word malaika, which means soft. And there are few syndromic associations also. You can see in this picture, tracheobronchiomalacia, how much it will be happening in inhaling and exhaling. So that is why the stridor is happening. The trachea has lost its inherent tone. Now we are going to the next scenario. A 21-year-old man was admitted with complaints of recurrent lower respiratory infections since childhood. So he's only 21. And he presents with episodes of productive cough with fever. And he was asymptomatic. Not a smoker, and no family history is there. And you can just see the chest radiographs are there and shows trachea and bronchia and bilateral bronchiectasis. A little bit enlargement is there. So it's a common syndrome that we find. So the origin is idiopathic. So this is tracheobronchomegaly. It's a Monier-Kern syndrome. So here we find trachea is slightly enlarged, more than 30 mm in this patient. These people also live among us. They only get diagnosed in the age of 30. And when complications happen in 50, 60 years only, we identify these people. Till then, they live like normal. And they get the symptoms get worse and when they have some allergies or dust allergy, etc. Now to the next question. common procedure that you see in your theaters. A 38-year-old man with a back pain undergoing a procedure. So what could this? You can see a needle is there. Some dye has been injected. Some dye or some procedure is going on. Just get through it. What is it? It's a vertebral level. Yep. I given some clues. It's a lumbar epidural steroid injection, just CT guided. So the more advantage is that it is a safe needle placement because it is under visualized. And all landmarks are based on bony projections, which with CT is better for. So while using CT, you can do RF neurolysis, alcohol neurolysis, nerve root blocks. Also, we can perform. Now, to the next question. It's a common finding. You can identify the pattern, something growing around there. This is called a tree in bud appearance. Which is mostly seen in the pulmonary tuberculosis. And actually, the airway is there, which is not visualized. But now the airway is seen just because something is obstructing mucus plugs and everything is obstructed it. That is why it becomes a tree in bud appearance. So differential other diagnoses are infections, congenital other disorders, connective tissue disorders, etc., malignancy. Usually, if it is infections are there, again, if the infections are treated, then this tree in bud appearance will disappear. Now, I added a wonderful slide also. What is this? What could this be? So this is a common scenario that if we can find in an ICUs, you can see something is there around a small ring, something a wavy thing is around there. So I hope you can identify it. So this is a micro CT. So just taken these days. These are also available these days. So it's an endotracheal tube scan section has been taken for an intubated patient. So you can see that inside how much secretions are there. The dark gray one you can see in the light gray one. The light gray one, this part is for the endotracheal tube, and this inside one is the secretions. Always we see the secretion so much when we have an intubated patient for more than 24 hours. So now we go few slides to the brain CT scans, and actually we know that according to the previously I've discussed that we have an isodense, hypodense, and a hyperdense depending on the CT number. So as it becomes, the density is higher, means whiter, more towards the bony part, and lower density means it becomes darker. So now we are moving to few scenarios after the traumatic brain injury and the brain scenarios. A 6-year-old girl presented with a severe headache for several days associated with vomiting, neck stiffness, fever, and an unsteady gait. She was recently treated for otitis media 1 week prior, and mother reported that the patient had frequent headaches and incontinence of bowel and bladder during the past 1 year. So the history gives many clues, and the CT is in front of you. You can see the mid part here. What is happening? It has been quietly enlarged. So I hope you can make your own basic guesses. Most of the CTs will be finding in we'll be find this set of CTs in our ICUs. Most of the doctors who are working also in ICUs. So we'll be much familiar with the findings. So this is a case of a hydrocephalus. So you can see that the ventricles are dilated to greater than the normal place. Causes could be non-obstructing and obstructing hydrocephalus. It could be either one of them. Now to the next scenario. So this is something concerning a hypertensive patient, sudden headache, signs of meningism are present. Few facts are like weakness and slurring speech is also present. So with the CT always we have to correlate with the history, and only we can get a diagnosis. So what could be it? I hope I get some comments. So this is an intraventricular hemorrhage. So history of hypertension, sudden onset of hypertension, old age, hemiparesis, worsening level of consciousness. And these type of patients will be presenting in the emergency. So we get an emergency CT, and this will be mostly the findings that we get. Over towards next question. A 25-year-old boy met with a bike accident with no helmet. So he was referred to a casualty and admitted in ICU. An emergency CT was determined to identify the extent of damage. So you can see a CT film here. So one more fact I'll add up is like blood is always white when on fresh and becomes darker after 2 weeks. So this person is being admitted fresh means suddenly he has been this CT might be had taken to 5 to 6 hours within his admission, and something is so white here. So it could be it will be blood. And also look for the history. So this is an acute subdural hemorrhage. You can also see the shape of it. It appears normal for a days after head injury and slowly a patient becomes confused and then pass out after several days. So blood collects under the dura, and this is a major type of traumatic brain injury. It cause our rupture of the blood vessels. So we should also think about the indications of emergency surgery of unstable, if etc. If we see this type of CTs. Now to the next scenario. Another man with an RTA, with an altered state of mind and a skull fracture and an emergency CT taken. So we can just visualize both sides. If you have a diagnosis, you can put in the comment box. You can see one side blood is formed, other side also something is there. So now we'll go. So this is an extradural hematoma, trauma to the left side with a contra injury on the right side. So this is usually a lens type collection and is formed due to the injury of the middle meningeal artery. And you can say one side injury and the opposite side injury are mostly found due to the acceleration and the deceleration forces. Another scenario we are discussing here. A 50-year-old female presents with a 2-week history of lack of interest. Patient and her family assume her symptoms are due to psychiatric condition. So they get it a history and a physical examination thoroughly done. And as a part of it also they are done a neuroimaging is performed. So on additional histories of headaches, loss of balance, increased irritability, and increased tone are also there. And a CT was done, and you can see some mass effect. So what could be the diagnosis? Okay. So highly it could be, two diagnoses could be glioblastoma multiforme or a cerebral abscess. So now we have an option for a contrast. So we can inject a dye and you can see how the differences are. So we can I'll just give it to comparison of two CTs, this one and the previous one. So there's a ring enhancement in both glioblastoma and in cerebral abscess, but there's an edema because of the inflammation in cerebral abscess. So that's the difference that makes out of it. Also, the history will give some suggestions. Now we go to the next scenario. A 72-year-old male with no past history due to acute onset of right hemiparesis and difficult speech. The most common scenario that we have seen in our medical wards, CT find suggestive of. I hope you can see. It's a dense MCA infarct. So it causes right side hemiparesis. So that's how you diagnose it. Towards the next question. A 65-year-old lady have a history of fall following with memory loss. Old age, small histories of fall with memory loss, speech deficit and difficulty in gait, and diagnosis of CT is added here. It's a subdural hematoma where the blood is pooling between the skull and the dura. We're moving towards the next scenario. 56-year-old male presents with history of a worst headache
Excuse
ever.
me, Jomy, I think we have to wind up a little more faster if you could move, because
Yes,
most
I'll finish
people
with
are there. Yeah.
I'll finish within 3 slides, sir.
Yeah, sure.
Yep. So as the diagnosis and the history, we know that this is the history of subarachnoid hemorrhage. And last scenario we are having, a 26-year-old male was admitted in RTA. Externally, there was not much injury, But after some time, his BP started to fall down. Emergency USG and CT scans were done, and he was rushed to. Definitely, he's rushed to a operation theater. You can see a splenic rupture and hemoperitoneum is present there. So with these small scenarios, I am ending up my small presentation. I hope you had something to learn from it. And finally, the boy is also getting a little bit bored up, and he started to see some aliens out of the window. His curiosity is also started a little bit to reduce. Thank you for this opportunity, sir. Over to the next person. Thank you, sir.
Thank you very much, Jomy, for that comprehensive discussion on various scenarios. And we'll take up questions at the end. And moving on forward, we move to the next speaker, that is Dr. Elizabeth. She's going to talk on ultrasonogram for the thorax. So Dr. Elizabeth is assistant professor at KMCT Medical College, and she has done her MBBS from CMC Ludhiana, MD from KIMS Hubli, and she also has a postgraduate diploma in law from National Law School, Bangalore. Over to Elizabeth.
Good evening. Because of the time constraint, I may have to run through my slides. So the BLUE protocol is a standardized approach widely used by critical care providers for diagnosis of acute respiratory failure. It is a very fast protocol, like it can be performed in less than 3 minutes at the bedside, provided that you have an ultrasound, and has a very good diagnostic accuracy, more than 90% for diagnosing these common lung conditions, your asthma, COPD, pneumonia, pneumothorax, pulmonary edema, and pulmonary embolism. So the specialty of lung ultrasound, unlike any other ultrasound, is that it is purely artifact based. You don't see the normal lung parenchyma at all. All we see are artifacts. So if we attempt to do a thorough, complete lung ultrasound, it takes approximately 20 minutes because you have to examine each hemithorax in the anterior, lateral, and posterior zone by placing the transducer in transverse and, in the longitudinal orientation. But in a BLUE protocol, which is done in an emergency situation, we are going to scan only these 3 blue points. They are the upper blue point, the lower blue point, and the PLAPS point. So we come to the first scenario where a subclavian central line insertion was required for a patient undergoing GA. So prior to placement of central line, we did the lung sliding sign, but unfortunately the central line required multiple attempts. So now you are placing the ultrasound probe on the chest again and looking for what? You're going to rule out pneumothorax. So these are certain signs that we are going to look for the presence or for the absence to rule out pneumothorax. So we prefer a linear probe for detection of pneumothorax because they have the best resolution for superficial structures like detecting a tiny pneumothorax. But don't use a linear probe if you can help it, because it is not going to show any anatomical relations. Like, for example, you might be placing the probe on the liver and assuming that it's a consolidated lung. And also, if you're looking for artifacts like B-line, once again, avoid the linear probe, because the linear probe is capable of imaging structures in very fine detail that it may tend to obliterate artifacts, like it's true for B-lines. So this is the best starting position of placing the transducer for detecting pneumothorax. So you can see that the probe is placed in longitudinal orientation. The marker is faced towards the head end of the patient, and you're anchoring the probe between the 2 ribs. So here you're scanning the highest part of the lung because as a rule, air is going to rise up. So this probe is going to emit ultrasound waves to the pleura, and in the normal lung, most of these ultrasound waves, they will be reflected at the pleura. So we see this hyperechoic pleural line seen as this bright white line. And if I'm seeing movement along this bright white line, like tiny ants moving, there is no pneumothorax. So this is the lung sliding sign. If the lung sliding sign is there, you have ruled out pneumothorax. So this is because, the visceral pleura is going to slide over the parietal pleura, distorting the ultrasound waves that are returning to the probe, producing this sign. So if you're not sure about the lung sliding sign in a 2-dimensional scanning, you activate the M mode. So on the screen, this vertical line will appear, and using a trackball, you move the line so that it's going to intersect the pleural line. And this M mode, what it does is it takes the depth from your 2-dimensional image and it's going to plot it against time. And on the corresponding M mode image, we can see the pleura again. And you see this grainy artifact below this pleural line. It's like a sandy beach, and we call it as the seashore sign. And above the pleura, the chest wall is going to be all stationary, creating the smooth horizontal waves, like waves in a beach. Now, this is an image taken from a patient with pneumothorax. So you can see the parietal pleura. There is absolutely no lung sliding sign because there is air in between the visceral and parietal pleura. So you can't see the visceral pleura. There is no contact between the pleural layers. So there is no lung sliding sign. You can also see another artifact, which is like equidistant from the probe, like twice as deep. And that is the air line. And don't confuse it with the pleural line. So in the M mode, first again, identify this parietal pleura, and then you find this corresponding echogenic line on the M mode image. So above this line, the structures, they are going to correspond to the chest wall, and below this line, what are we expecting? We're expecting to see the sandy beach sign, but we do not see it. So this is known as a stratosphere sign because everything, it looks like a stillness of the outer space. So, absence of lung sliding sign, it does not confirm pneumothorax because it may be absent in these following conditions. Like in cases of ARDS and, there will be this inflammatory exudate fibrosis, which is going to adhere to the lung, to the chest wall, making the complete absence of lung sliding sign. So what do we do now? Like we are going to look for other signs, which is like another artifact, which is the lung pulse. And it is defined as, pleural line because of transmission of cardiac pulsation. You can see this in the M mode image. So why do we use the lung pulse? Because even if lung sliding sign is absent because of the situations I have explained before, there might be a lung pulse present. So this is the M mode here. Again, we're looking for landmarks like the pleura, and we can see these regular rhythmic disturbances that are coming mostly from the pleural line, and they're repeating themselves at regular intervals. And you can see that this pulsation is stopping at the pleural surface. So this is lung point, another artifact, very important clue to diagnose pneumothorax. 100% specific to pneumothorax, because this point in this pleura where you can see that there is a clear lung sliding sign on one side and there is an absent lung sliding on the other side. So this is because in a patient with pneumothorax, we can demonstrate, this transition point between pneumothorax and normal lung on the same image, and that is the lung point. Okay, but in a patient with complete pneumothorax, you will not see lung point because the entire lung will be collapsed. So, what do? You start off with placing the transducer on the anterior chest wall, and, you place it in the long axis. First, identify pneumothorax. So here, the blue is representing the free air. So to find the lung point, we need to get to the border of the blue area so that the transducer, you have to place it parallel to the ribs, and you move it laterally till the lung point is identified. So the more lateral or posterior the lung point sign is, the larger will be your pneumothorax. And if a lung sliding sign is not visualized anteriorly, you can move the probe to more lateral, posterior position, searching for this lung point. So this is the lung point in the M mode. You can see the transition between that seashore sign and the barcode sign. So this is another demonstration of this lung point in the M mode image. So the next artifact is the B line. So these B lines, they are these hypoechoic vertical artifacts. They are arising from the pleural line. And, they extend all the way down. Okay, so the presence of even a single B line proves that there is no pneumothorax. So you can see that they're extending all the way down to the bottom of the screen. So mostly implies that this patient has pulmonary edema, but it may also be present in these situations like atelectasis, consolidation, and interstitial lung disease. And also in subcutaneous emphysema, you may have an artifact which looks like B line, but it's going to arise somewhere even more superficial, to the pleura, not from the pleura as such, as seen in the B line. So the bottom line is, if you see even one B line where you have placed the transducer, you have completely excluded pneumothorax at that place. If there is lack of B line, you cannot make any conclusions regarding pneumothorax, and the negative predictive value of B line is extremely good. So the next artifact is an A line. So A line, they are not real structures. They are just reverberation artifacts from the pleural line. If B line is present in A line, so you cannot expect to see A line on the same image. And it can happen in a normal lung and also in a lung with pneumothorax. So how do we differentiate if there is a pneumothorax? There won't be the lung sliding sign, and lung point should be present, and also B lines will be absent. So this is the next scenario where you have a 50-year-old with very high fever and sharp stabbing pain coming to the ER with tenderness and mild dullness on percussion and with decreased breath sound. So from your clinical history, you're expecting to have pleural effusion. Okay, so this point is known as the PLAPS point, okay, where your posterior axillary line is going to intersect with your lower blue point. So while scanning for the pleural effusion, you're going to scan the lowest part of the lung because as a rule, fluid is going to sink. So in a supine patient, this will correspond to the posterior chest. So that is known as your PLAPS point. So this is a USG visualization of a normal right upper quadrant view. So you can see the liver, the lung, as well as the kidney, and you can see the diaphragm as this, this curvy white line which moves with respiration. So if you were to imagine the liver as a fluid-filled structure and the lung as an air-filled structure, and this diaphragm to be like a mirror, which is a very highly reflective surface for sound, this will result in the mirroring of liver. The lung is going to mirror the liver, known as a mirror sign. Now, this is a normal left upper quadrant view. So here again, you see the lung, the spleen, the kidney, the moving diaphragm, and again, the same mirror artifact. We are seeing the lungs as the mirror image of the spleen within this thoracic cavity. So this is a right upper quadrant view with pleural effusion. So we are seeing the pleural effusion as an anechoic structure in this. And this is a left upper quadrant view, and you can see a very small pleural effusion seen as a very dark and anechoic fluid collection above the diaphragm. And now this is a moderate pleural effusion. This is again taken from the right upper quadrant view. We can see the liver, the diaphragm, and the pleural effusion. And we can see that the lung is moving around in this fluid, and it looks like a liver in the chest. And this is known as hepatization of the liver. This is because the pleural fluid is just going to push against the lung, making it a solid type of an organ. But the same sign, you call it by the jellyfish sign. It's nothing, but it's just the consolidated lung seen floating in this pleural effusion. Now, we can also see the spine sign. You can see the thoracic vertebral bodies above the diaphragm. That is also indicative of pleural effusion. Now, this is a loculated pleural effusion. It's a right upper quadrant view. And in this example, you can see a nice whale tail sign with B lines with each breath. This happens when there is not a lot of atelectasis. This patient has pulmonary edema with bilateral pleural effusion. Now, this is a pneumonia. There is an infection which is going to fill the alveoli with fluid, and the consolidation is going to get separated from the surrounded lung, and it has an irregular margin, and it looks like torn paper. That's why you call it as the shred sign. Now, this is an example of cardiogenic pulmonary edema. So in CPE, you have this increased hydrostatic pressure, which is going to cause the fluid to leak into both the lungs. So you're expecting to see what? The B lines. There's fluid, there will be B lines. But here the B lines, they're going to just converge into vertical sheets. They are known as confluent B lines. So instead of B lines, you're seeing sheets of B line. So this is a very busy slide. It's an algorithm of this blue protocol decision tree. So if you use the ultrasound alone, you would have a 90% accuracy in arriving the diagnosis. So always integrated with a clinical scenario. So thing is, if your patient is blue, promptly initiate the blue protocol. So you can see that this algorithm is starting with, checking whether there is the lung sliding sign. So the presence of lung sliding sign is going to straight away rule out pneumothorax. Then you have the B profile, which is suggesting a pulmonary edema. Then you have an A profile where you're searching for venous thrombosis. Then you have a B prime, A, B, C profile looking for a pneumonia. So see, A profile is you have predominant A lines, B profile, you have predominant B lines. And the C line is this consolidation line of pneumonia. So in an A prime profile, you have an absent lung sliding sign and without the lung point. So with this, I come to a conclusion of my slide. I'm extremely sorry if it's too much of a speed. Thank you so much.
Thank you, Elizabeth. That was a crisp presentation on USG of the thorax. And we'll take up the questions at the end. So we move on to the next session. We move on to radiographs, that is X-rays. That will be done by Dr. Dhivya. Dr. Dhivya Jacob, she's done her MD from Spiri Medical College, and she also has a DNB along with postgraduate diploma in medical law and ethics from NLHUI, Bangalore. She's presently the assistant professor at Department of Anesthesia, KMCT. Over to Dhivya.
Thank you, sir. Good evening, all. Thank you for the opportunity given by ICA. Today, I'll be presenting X-rays for the anesthesiologist. I now apologize because of the time constraints. I would like, I probably will be rushing. So how will we go about with X-rays? Now, X-ray is one of the most mandatory tools in PAC that we as anesthesiologists come across. So what about how to go about the systematic analysis of X-ray? The first one is labeling to know whether it is the right patient. Next is a projection. That is the most common projection that we are getting is the PA and the AP view. Next is the site, whether it's the right, left, then exposure or penetration, the scapular position, the timing, and the adequacy of the fillet. Now, the most important projection that we come across is PA and AP. In PA view, the most important thing is you have the scapula, which is clear of the lung feeds. And in AP view, what you're seeing is a complete cardiomegaly or an apparent cardiomegaly. Now, the most common approaches that we are using is the ABCD approach or the center to periphery or a periphery to central approach. In ABCD, right, like the synonym says, airway, that is trachea or bronchi, breathing, which includes the lung fields, circulation, that is the cardiac, diaphragm, and everything else, like the soft tissues, bones, lines, and tubes. And coming to the most commonly used systematic analysis is from the periphery to the center. As you can see, you can see the soft tissues, the skin, the subcutaneous tissues, and the breast shadows. And you can see the bones and the thoracic niche. In the bones, you'll be looking into clavicle, the thoracic vertebrae, and the cervical vertebrae, the manubrium sterni, and the manubrium sterni, along with the other parts of the sternum, and the ribs. And next comes the air column, that is the trachea, then the mediastinum and the heart, the costophrenic ankles and the cardiophrenic ankles, and the hilum and the lung, along with its fissures. Now, coming to the heart, you have the heart size is important, the shape is important, the diameter is important, and in an AP view, like I've told, it is showing apparent cardiomegaly. So heart has got cardiothoracic ratio. So as you know it is a ratio between the cardio as well as the thoracic ratio. So that should be always less than 0.5. Now, if it is more than 0.5, it is cardiomegaly. Now, you can see the right heart border and the left heart border. In the right heart border, you have the SVC, the ascending aorta, the right atrium. In the left comes the aortic arch, the pulmonary artery, the left atrium, and the left ventricle. Now, important is the right ventricle won't be seen in the heart borders. Now, coming to the diaphragm, as you all know that we have two hemidiaphragms, the right and the left one. The right is quite upper and the left is pushed down. Yes, so the right one is pushed up basically because of the liver, and usually you have a difference of 2. And if there is a difference of more than 3 or more, then it is abnormal. And in the lateral X-ray, always the right hemidiaphragm is seen as big. Now, coming to the lung zones, it is divided into the upper zone, the middle zone, and the lower zone. Now, as you trace it, you always need to trace it from posterior. You trace the ribs from posterior to the anterior. So the upper zone corresponds to the anterior end of the rib, to the second rib. The middle zone is from the second to the fourth, and the lower zone is from the fourth to the sixth. So as you can see in the lung, you have 2 fissures, the horizontal fissures for the horizontal and the oblique fissure for the right lung, as well as the oblique fissure for the left lung. Now, the next one you have to see is the lines and the tubes. Now, ACR, or the American College of Radiology, recommends a chest X-ray immediately following placement of indwelling tubes, catheters, or anything. So in lines or tubes, of course, you can see the endotracheal tube tip. We are always sure that it should be midway between the carina, and it should be at the medial, at the level of the medial end of the clavicle. Now, this is a picture of the ICD. So in pneumothorax, the ICD should be placed anterosuperiorly to drain the pneumothorax, and it should be placed posterior inferiorly to drain in pleural effusion or hemothorax. In central venous catheter, the tip of the CVC catheter should be placed at the superior cavo-atrial junction or at the first anterior intercostal space above the. Now, this is a picture of the tracheostomy tube. The walls are parallel. It should be parallel to the long axis of the trachea, and it should be seen several centimeters above the trachea. Now, coming to the X-ray, it is a lateral airway X-ray. Now, what we are seeing is you can make out the soft tissues like adenoids, pharynx, and one of the most important structure that we should look in is the epiglottis, which remains as a leafy structure. Just below that, you can see the pyriform sinus, where the most common foreign bodies are dislodged. You can see the valleculae just above, between the above the epiglottis. And in the bony structures, you can see the hyoid bone, the vertebral bodies, cervical vertebral bodies as well. Now, how do you know there is a rotation? If there is an alignment of manubrium rami is different, then there is a rotation. And exposure depends upon whether there's a clear visualization of the vertebrae or the soft tissues. Now, in relation to the bony structures compared to the airway, the hard palate corresponds to C1 vertebrae, the oropharynx is C2, the hyoid bone in between C3 and C4, the laryngopharynx is after C4. Now, these are some case scenarios that I would like to design. The first one is a cervical spine. See, here you can see the fusion of, in the lateral neck X-ray, you can see the fusion of the cervical vertebrae. Here you can see the military neck. Here it is a normal neck where there is a cervical lordosis, and that is lost in military neck. This is commonly seen in scoliosis. Now, this is fusion of the cervical spine that is seen in Klippel-Field syndrome. Now, this is another lateral X-ray neck where you can see the retrosternal goiter, and you can see that there is narrowing of the trachea. Now, this is actually a neck mass which is seen in AP neck X-ray view. Here, we'll be able to visualize the narrowing as well as the deviation in trachea. Here, you can see there is a neck mass which is actually a calcified thyroid nodule. Now, in the neck X-ray, especially in children, they will come to you with throat pain. So epiglottis is seen. As you can see, the classic thumb sign is seen, which results in narrowing of the epiglottis, which is seen in acute epiglottitis. Now, this is called as a steeple sign. This is classical in children. This is a croup showing subglottic stenosis. Now, moving on to chest X-rays. Now, here you can see the right upper lobe consolidation. This is an aspiration pneumonia in a child. You can see the right upper lobe pneumonia consolidation where there is a homogeneous opacity. Now, here you can see a characteristic left homogeneous opacity, which is a consolidation characteristic of pneumonia. Also, in the same X-ray, you can see the air bronchogram. That means it is actually a radiological sign where air-filled bronchi is against a background of opaque airless field. So it is showing proximal airway patency. Now, this is actually a picture of a COVID-19 patient having ground glass opacities and consolidation with bilateral and peripheral. There is bilateral and peripheral redistribution in COVID-19. So as you can see, this is the day 1, day 2 to day 5 X-rays. Now, this is a classical ARDS picture where this is day 1, day 2, and day 3. You can see bilateral alveolar consolidation with pan-lobar chain. This is the classical ground glass opacities, basically, which is seen bilaterally. Now, this is an empyema chest X-ray. You can see the classical air fluid level to the chest wall. There is extension of the air fluid level across the fissure lights. The tapering border of the air and air fluid collection can also be seen in some X-rays, and usually it is an obtuse angle with biconvex or lenticular shape. Now, here, this is an X-ray of a lung abscess. Here you can see that there is an air fluid level. It's a shaped cavity. Mostly it is found in the right upper lobe, but here you can see it in the left middle lower lobe. Now, this is a picture of a right total lung collapse. This is showing atelectasis. Here you can see that there is volume loss. There is mediastinal shift to the right. Then there is elevated hemidiaphragm. There's elevated hemidiaphragm, and there is dense shadowing across in the collapsed lobe. This is interstitial lung disease. Here you can see the classical reticular pattern. There's honeycombing, as discussed before. There is ground glass opacities, and there is multiple pleural thickenings as well. Now, this is a X-ray showing different features in pneumothorax. This is tension pneumothorax, as you can see. Here, you can appreciate the visceral pleural edge. There is free air, which is present. The mediastinum, the collapsed lung is present, and the mediastinum is pushed to the contralateral side. This is again a picture of tension pneumothorax where you can appreciate the mediastinal shift. It is on the right side. It is the mediastinum is contralaterally pushed to the left side, and there is flattening of the diaphragm in the right side. There is widening intercostal space due to increased intrathoracic pressure. Now, this is another X-ray of showing a right hydropneumothorax. As you can see, this is an upright film with an air fluid level Now, if it was taken in supine AP view, then you could appreciate a sharp floral line. Now, this is another picture showing pneumomediastinum, where you can see the classical double bronchial sign. That is air in between the mediastinum as well as the pleura. So the double bronchial wall sign is seen in pneumothorax, and in children, or especially neonates, you have the angel sign. Now, this is an X-ray of pleural effusion. I hope you can appreciate the pleural effusion, bilateral. Now, as you can see, the opacification is present bilaterally. And as you can see the Silhouette sign. So what is Silhouette sign? It is loss of interface between the lung and the soft tissue. Okay, it is absence of depiction of soft borders. Then you can see the classical meniscal sign, where the fluid is getting accumulated in shape of the pleura. Now, this is another X-ray showing COPD. You can see the hyperinflated bilateral lungs, the presence of a bulle around, and the classical, the wall of the blood is here, and a vertical or a tubular heart. Now, as anesthesiologists, sometimes we come across primary lung tumors or even metastatic lesions. So how do they look? So in primary lung tumors, then as in this one, you can see a mass, or sometimes it can be a solitary nodule like this one, or sometimes it might go with a cavity or a hilar enlargement. In metastatic lesions, as you can see multiple lesions. Now, it is a cannonball appearance. It usually comes from breast. Now, coming over to the cardiac slides, what is pulmonary edema? So in pulmonary edema, you have the classical bat wing appearance and the stag antler sign showing the depth. I hope you can appreciate the stag antler. So in that is because of the pulmonary venous congestion. So in pulmonary edema, usually you go with A, B, C, D, E. Again, A, B, C, D, E. So what does A stand for? It is alveolar edema or bat wing appearance. Then curly B line, that is the interstitial edema that you will be seeing. Then cardiomegaly, which is appreciated as more than the CTR is more than 0.5. The distal prominal upper lobe vessels, that is the cephalization and the bilateral pleural effusion. In pericardial effusion, this is another slide showing enlarged cardiac slot. That is, the soft tissue is again not appreciated much. So the classical water bottle or the money bag appearance is classical pericardial effusion. In mitral valve stenosis, you have the enlarged left atrium. So the heart border, in that you can see the enlarged left atrium. Now, this is implantable cardio defibrillator. Now, you can see that there are two, it is usually placed in the left infraclavicular area. Now, one, you can see the first pacing chamber, it is in the SVC, and the second one is in the right ventricle. Now, what can you appreciate in this? I hope I'll get in the comments. So this is actually a prosthetic valve, and this is a post-CABG. This is post prosthetic valve and with sternal wires as well. Now, what are the signs that we'll appreciate in pulmonary embolism? The classical Hampton's hump. Now, what is Hampton's hump? Basically, it is a radio opaque area showing features of pulmonary. It's a dome-shaped opacification where classically seen in pulmonary infarction or just prior to pulmonary infarction. Now, the Westermarker sign, which is the classical pulmonary oligemia that you'll see, and the Pallas sign, where the descending right descending aorta, pulmonary artery is dilated, which is also classical in pulmonary embolism. Now, TOF, as you can see in a child, you see the classical boot-shaped heart. There is cardiomegaly and small pulmonary conus. Now, this is another picture with central line malpositions, where I'm sure you will be seeing it multiple times in your ICUs. But I would like to discuss this. See, even central lines can even get malpositions in the aorta. This is a foreign body esophagus. Now, as you know, how do we differentiate foreign body esophagus with bronchi? Is when you take a lateral one. You can see the trachea, which is kind of patent, and also there is no hyperinflation of the lungs. Now, what happens when there is a foreign body in bronchi? So this is actually an X-ray where there is foreign body in the right main bronchus. So you will see that there is a hyperinflation of the right side due to a ball valve mechanism. So any air which is, no air can be expired out. But always remember that X-ray is not the conclusive. The conclusive is to do a bronchoscopy. You can also have a normal chest X-ray in a foreign body bronchus. Now, this is actually an X-ray with anterior mediastinal mass where you will be dealing with 5 T's. That is thymic neoplasm. You'll be wondering whether it's a teratoma, a thyroid, a terrible lymphoma, or a thoracic aorta. So what is this? So this is another picture with a retrosternal goiter, which is actually presenting like a anterior mediastinal mass, basically. You can see there is a trachea is deviated, there is mediastinal shift, basically there is narrowing, etc. Now, this is a picture with a thymic, with the classic thymic wave sign, that is wavy border along. I hope you can appreciate the wavy border of the thymus. Now, this is actually a picture of a CDH child. You can see this is a picture with the left hemithorax filled with cystic structures showing loops of bowel. The mediastinum is shifted to the right and the abdomen is devoid of gas, basically. This is a classical thing with tracheoesophageal fistula, where you can see that the NG that we place is coiled. This is a picture of kyphoscoliosis. Now you can make out wedge-shaped vertebral bodies. This is the wedge-shaped vertebral bodies, asymmetric rib spacing, elevated hemidiaphragms, reduced lung volumes with restrictive airway disease. Then you have the classical Hobbes angle. I hope you all know that. This is another picture showing X-ray showing the flail chest. You can appreciate. Always remember, whenever we are tracing, it is from the posterior to the anterior. We have to trace the ribs. Here you can see this is the subcutaneous emphysema X-ray, where you can see that there is air in the subcutaneous plane, and it is called as the ginkgo leaf sign. Now, this is a ginkgo leaf. You can see the subcutaneous plane. Now, this is a X-ray showing pneumoperitoneum, where you can see air under the diaphragm in an erect X-ray. And same holds for another one is the football sign, which is showing a large pneumoperitoneum. So this is the classical football sign. This is abdomen. In abdomen, you can see the single bubble sign, the double bubble sign, and the triple bubble sign. And that double bubble sign, as you can know, it corresponds to duodenal atresia. Triple bubble sign, it corresponds to jejunal atresia. And in abdomen, we are all worried about usually when laparotomy cases come. So it is always small bubble in, obstruction. So you can see multiple air fluid levels. So this is a barium study, which is showing the classical dilated esophagus with the classical bird beak appearance. That is for eclasia cardia. So there is a diffuse dilatation of the esophageal body with bird beak appearance. With this, I conclude my slide. I hope you all could follow me. Thanks a lot. Thank you, sir. Over to you, sir.
Thank you, Dhivya, for that crisp presentation. And we move on to the final session of the day and a very important topic on point of care ultrasound. So I invite Dr. Shahid to share his slides. Dr. Shahid is presently working as senior resident at KMCT Medical College. He has done his MBBS from Calicut Medical College and MD from AIIMS Jodhpur, and he also has a DNB. Over to Shahid.
Thank you, sir. And we'll move on to the final topic for the session, POCUS abdomen. And obviously, we'll be having time restraints and going on to the first slide. And first of all, I would like to talk about this probes present, ultrasound probes which we commonly use. These are 3 types of probes. Linear probe, which has low frequency, low resolution, and higher depth penetration, and high frequency linear, which higher frequency, higher penetration, lower penetration. And these are mostly used for skin or musculoskeletal usages. And curvilinear probe, which has low frequency and high penetration, and also the phased array probes which are used. And always look for the probe markers before usage, and screen indicators can be present, which denotes the site of the usage. And moving on to the POCUS abdomen, 3 topics are to be our anesthetic concerns: EFAST, or the focused assessment of the sonography in trauma, which will be the first topic, and gastric ultrasound and IVC. On to the first topic, EFAST. FAST is an acronym for focused assessment of sonography in trauma, which are most commonly used in emergency scenarios. And 4 basic views are used for examination, are looked into the examination. These are perihepatic, or right upper quadrant, perisplenic or left upper quadrant, pelvic or suprapubic, and pericardial or subxiphoid. These are moved in a sequential manner. And then there is extended fast, where we include the assessment of the lung and pleura bilaterally. And this is majorly done when there is a hemodynamically unstable patient or shock patients. We visualize all of the viscera. We are looking for free fluids or free air in the peritoneum. And onto the four quadrants which are being visualized in the past. Right upper quadrant, we majorly examine the hepatic spaces, the liver spaces, hepatorenal pouches or Morrison's pouch, the pleura, the subphrenic space, and inferior pole of the kidney. Then we move on to the left upper quadrant, where we'll be visualizing the spleen and inferior pole of the kidney, the splenorenal spaces, the splenic, subphrenic spaces. And then to the suprapubic space, where we'll be focusing on the retrovesical pouch on the males and pouch of Douglas or retrouterine pouch in females. And then finally to the subxiphoid space, where we'll be observing the pericardium for accumulation of fluids or hemopericardium. And then in EFAST, we extend it onto the lungs as well. And onto the first examination, the right upper quadrant examination, the patient is positioned as supine and with hands extended or abducted. And then we'll be placing the curvilinear probe or a phased array probe onto the perpendicularly placed on the mid-axillary line between the 8th and 11th rib spaces. And we'll be observing the hepatorenal space, where you could see in the diagram, and on the right top diagram where you could see the accumulation of the fluid in between in the Morrison's pouch. And this is a videographic image of the same. And next examination will be onto the left upper quadrant, where the probe is placed on the mid-axillary line between the 6th and 9th rib space. And probe indicator is directed towards the patient head. Similarly, we'll be visualizing the spleen, kidney, the splenorenal space or perisplenic places. Here, you could see the fluid accumulation or hypoechoic accumulations around the spleen or on the splenorenal recess. And then we move on to the suprapubic examination, where the probe is placed on the suprapubic, and this is rotated downwards. We can examine it as transverse or in the longitudinal view. And here, this is a female suprapubic examination, where you are seeing the bladder, uterus, and the retrouterine space of pouch of Douglas. And here is the male examination, where there is a retrovesical space, and fluid accumulation can be seen in pneumoperitoneum. Then on to next onto the subsequent examination, the probe is placed on the epigastrium and indicator is placed towards the patient right and pointing towards the patient left shoulder. And here we could encourage all the chambers of the heart, and the pericardium is also visible, and liver is visible towards the probe end. And on subsequent examination, majorly we'll be focusing on the global ventricular function and the pericardial effusion, the cardiac tamponade, as well as the IVC analysis for its diameter, collapsibility, distensibility, etc. And this is an image where there is an fluid collection or hypoechoic collection, where we could see in between the cardiac chambers as well as the pericardium, the hemopericardium. And here there is a fluid accumulation seen, but also you could see that there is a diastolic right ventricular collapse seen in the cardiac tamponade, Beck's triad, which is clinically visible. And finally, on the EFAST, we move on to the thoracic view, which has been detailedly covered, and where you could see this normal sliding sign in normal lung. And in the pneumothorax, there is no lung sliding, as well as the barcode sign is seen on the M mode. On to the next topic, the gastric ultrasound. Gastric ultrasound has been the recent advances in the field of anesthesia, where the gastric most commonly used when the gastric contents are uncertain. When the history of the patient is unreliable, the patient's NPO status is unknown, and the patient is of high risk of aspiration, and when the patient is having gastroparesis, or when the patient has delayed gastric emptying in cases such as the diabetes, pregnancy, obesity, all these cases. Gastric antrum is of greatest interest because of its consistent location and of easy visualization. And gastric ultrasonography is being done on two positions, the supine and then on the right lateral decubitus position. The right lateral decubitus position is necessary for an accurate exam because it ensures all gastric contents, particularly even in the low volume states, have shifted towards the gravitationally dependent antrum and are accounted for in the scan, and nothing is missed. And you should know about the critical volume threshold for a gastric fluid. It is at 1.5 ml per kg. Anything more than 1.5 ml per kg, we consider it as increased risk of aspiration. As you can see, patient the curvilinear probe is used. It is placed on the epigastric region in between the xiphoid process and the umbilicus, and indicator pointed upwards, and you can rotate it and visualize the IVC as well. Then it is seen on the supine or semi-sitting and right lateral decubitus position. And for identifying the antrum, it is present just close to the liver and towards the left lobe of liver, and it is present anterior towards pancreas and the great vessels. As you could see in this diagram, the left lobe of liver is visible, the gastric antrum is visible, the pancreas and the great vessels of the abdomen. And this is an image obtained when the patient is having an empty stomach, where the gastric antrum is seen as a bullseye appearance, where the antrum is small and non-distended. And this is an image where you could see the antrum is distended and there is hypoechoic, and air bubbles can be seen, or starry night appearance can also be seen in presence of small liquids. And in this image, if you're getting this image in a gastric ultrasound, wait for at least like 10 seconds so that the peristaltic component is being ruled out. And also for the measurement of the liquid components, the diameter is measured, you could get the antral surface area. From the antral surface area, you could get the volume, gastric volume, and this gastric volume can be accounted as we learned prior. The 1.5 ml per kg is the cutoff for the gastric antral volume, and anything more than 1.5 ml per kg is accounted for as high risk of aspiration. And this is an image where you get when there is a solid condenser present, where the patient is at high risk of aspiration, which has a frosted glass appearance. So obviously the patient is examined in both supine and lateral position, where you could get no content, clear fluids or solids accordingly. So it can be graded as 4 grades: 0, 1, 2, and 3. 0 is when it is empty in both the positions, and 1 is when it is empty in supine position, but clear fluids are visible in the right lateral decubitus position only, but it is of less than 1.5 ml per kg, therefore it is of low risk of aspiration. And grade 2 is when clear liquid is present in both the positions and it's of great significant volume of more than 1.5 ml per kg, it is high. And it's grade 3 when solid components are present. And grade 2 and grade 3 are accounted as high risk of aspiration. On to IVC. IVC was used to predict the fluid responsiveness and also to evaluate an hemodynamically unstable patient. And how does IVC size predict the fluid responsiveness? Depending on the respiratory variations, there can be changes in the IVC diameters due to the changes in the intrathoracic pressure, and this can determine the fluid responsiveness on the patient. In a spontaneously ventilating patient, IVC collapses in the inspiration due to the negative intrathoracic pressure and increase in the venous return. And there we used to measure IVC collapsibility index. Or during a mechanical ventilation where a positive pressure is being given, the IVC, the venous return is decreased and IVC dilates during inspiration, and IVC distensibility index is being measured. Anything distensibility index of more than 80% in the mechanically ventilated and collapsibility index of more than 50% in a spontaneous ventilation detect the patient is fluid responsive. Now, on the IVC longitudinal axis view, the phased array probe is used on the subxiphoid level, and IVC is observed so that it is just entering the level of the right atrium, and also the hepatic veins confluences are also seen, and measurement of IVC is taken 3 centimeters away from the joining of the right atrium and close to the hepatic vein confluence. And here you could see 2 echo images, subsequent images of the IVC, where in the first image you could see a dilated and non-collapsible IVC, which is suggesting of high CVP, central venous pressure, mostly due to an obstructive or cardiogenic shock, but we have to relate clinically. In the second, you could see a small and collapsible IVC, which is suggestive of low central venous pressure, which is of distributive hypovolemic, maybe. And in a ventilator patients, for measuring the IVC, the patient should be following the following criteria: that is tidal volume of more than or equal to 8 ml per kg, with a PEEP of less than or equal to 5 centimeter, and having a normal sinus rhythm. Then you measure the IVC, and distensibility index is being measured in a ventilated patient, where it is measured as the difference between the distension of the IVC to a IVC minimum diameter. Anything more than 18 is fluid response in case of distensibility index. This is the collapsibility index. Similarly, where M mode image shows the IVC diameters, which two diameters are taken of the IVC or minimum and maximum diameters, where IVC collapses during inspiration in a spontaneously ventilating patient. Therefore, we use a collapsibility index. So also, depending on the IVC diameter and percentage which is collapsible, we can estimate the CVP of the patient. 1.5 to 2.5 is the normal IVC diameter. So decreased IVC diameter with more collapsible suggests that it is having decreased CVP of 0 to 6.5. Of anything normal CVP which is collapsible shows that it is near normal CVP. So any normal IVC diameter which is less collapsible shows that it has slightly raised CVP. And anything which is dilated IVC which is less collapsible shows that it has high CVP obviously. So POCUS can also be used for fluid resuscitation of the patient, which is based on two things, that is IVC and lung ultrasounds. But these are not widely used now because of the less reliability on these, because IVC may not be dilated or may be dilated in even in there's like valvular pathologies, right heart pathologies, pulmonary hypertension, which cannot be accounted on this case. So this also earlier was used mostly for guiding the fluid responsiveness, fluid resuscitation in the patient. And slightly regarding the bladder ultrasound, in the first image, you could see an Foley's catheter properly positioned and also empty bladder in an inflated cuff. In the second one, you could see an malfunctioning Foley's and non-draining urine, which is resulting in the distended bladder. And slightly off topic, then ultrasound of the cardiac arrest, we use the same protocol. These are being used in the patient who are undergoing a CPR or post CPR, post ROC, where we could understand the reversible causes of cardiac arrest, such as pneumothorax, cardiac tamponade, pulmonary embolism, and to assess the contractility of the heart. It's all you could do now. Thank you.
Yeah, thank you, Shahid. And so with this, we end the 5 sessions. Over the last 2 hours, we have taken up 5 sessions, and we'll now go to the, we'll see whether there are any questions for the. Yeah, there's a question in the chat box for Dr. Sunny. Sunny, sir, you are available?
Yes, sir.
Yeah. Sunny, sir, there's a question from Dr. Suresh. He's asked whether USG can be used to measure right-sided DLT.
As far as the right-sided DLT is concerned, USG.
Can't hear you. I think. Can you? Yeah.
Now, sir, can you hear me?
Yeah. Yes, can hear you.
So, as far as the right-sided DLT is concerned, USG measurement is not reliable. Why? Because you know, in case of a right-sided DLT, the size of the bronchial cuff, that is very crucial for the proper lung isolation. So our ultrasound does not offer enough precision to measure the bronchial cuff diameter. So that is why USG is not very ideal to predict the size of right-sided DLT. And luckily, most of us use the left-sided DLTs.
Yeah, the margin of safety is better with the left side.
Yes, exactly.
Yeah, thank you.
Thank you, sir.
And there are no more questions in the chat box. So I would like to take this opportunity on behalf of all our speakers to thank Indian College of Anesthesiology, anesthesiologist officials for giving us this opportunity. And I hope these sessions were useful for the attendees. And over to Dr. Sanish for his comments.
Thank you very much, Dr. Vijish. Especially thank you for choosing this topic and getting a good team of resource persons to facilitate this topic. I think each of the topics that we have presented today have been exemplary and very useful to the youngsters as well as those who are actually interested in this mode of investigation. Right now, the imaging, most of the things are becoming a point of care investigations from anesthesiology point of view also. Thank you very much for your cooperation and for that excellent session. On behalf of Indian College of Anesthesiologists, I thank Professor Dr. Vijish Venugopal, who has been our resource person for many of our previous academic ventures as well. Thank you very much. And I profusely thank his team, including Professor and HOD Dr. Sunny Alex, Dr.Elizabeth, Dr. Dhivya, Dr. Jomy, and Dr. Muhammed Shahid. I think this session will be very useful for all the residents, and this video will be available later on in the ICA academic platform. It may not appear immediately on our YouTube platform like we used to do before. So thank you very much for continuing with our ICA academic initiatives. Thanks each of the delegates who have joined live for this excellent session. Keep joining ICA webinars on all the Wednesday evenings to come as well. Next week, we'll have a special World Anesthesia Day episode coordinated by Dr. Mukul Kapoor. Thanks again. Good night. We'll keep in touch.
Thank you, Suresh. Thank you.
Thank you so much, sir, for the wonderful deliberation and informative content that you have shared to make this session a success. It was a pleasure to host this session. See you again. So, with all your permission, we will be ending the session here. Have a good night to all.
Thank you. Good night.
Thank you so much.